Hi, everybody. Good morning. I'm here with Amrita Sethi. We used to say from New York, but it's now from Chicago.
Soon.
So welcome. And shining the light into endoscopy, we are shining the light through holes, right?
Yes.
And the two of us decided that a hole is a hole. It's not a defect you can look through. So we do not talk, at least for the moment, about closure of defects after resection type of thing. So Amrita, there are two very, very different situations when we talk about holes. One is we make a hole unintentionally and then everything is allowed and we are happy if we can close it, which is mostly the case, but the bar is not so high. The other situation is an intentional hole. So we're going into a procedure where we have a transmural resection, and there the bar is very high because we cannot afford that out of 10 goes to surgery, basically, right? So shall we start with the kind of emergency situation?
Yeah.
So you do, let's say, most frequently in the colon, you have a larger EMR and you have a small hole.
Yeah.
But there's still a polyp in. Part of the polyp is still in.
It's still there.
Yeah.
Okay. And okay. So that's a good point. And before, I think if we were in that situation, there would be immediate panic. And there would be the question of should we come out and send this patient to surgery? But things have completely evolved now. We look at the hole, we don't panic, we take a deep breath. And for me, I assess the situation. Is the patient okay? Is there a lot of stool around or content that might be leaking out? How much polyp material is left? Because if the hole is not so big, I would actually continue to take the rest of the polyp off. And before I do that, also I have to make an inventory. What are the devices I have available to me? And if they're not immediately in the room, I ask for people to start to gather all of the devices. I have to think about where are we in the colon? Are we on the right side or are we on the left side? And how difficult was it to reach this space? Very sigmoid, very tortuous colon, a lot of diverticula. Will it be difficult for me to come back here if I need to put a large device in? So again, these days we have so many devices that actually let us just stay in place and not have to take the entire scope out and worry about immediately getting the patient to surgery. So again, I would assess if I feel like I have some good tools to close it, I will finish removing the polyp, and then I will make the plan to close. I would give the patient antibiotics immediately, and also have someone constantly assessing the patient's abdomen, making sure it's not becoming tense, seeing if we need to do a decompression. But I would say it has not occurred probably in the last few years that I've had to send a patient to surgery for an acute perforation with an EMR or an ESD.
A few questions to that. Some of what you said should probably be there before you start the polypectomy, like a clean colon.
Yeah.
And also clips or devices being in the room, because it's bad if the nurses have to run around and where's that thing, and right?
Yeah, absolutely. The room should be stocked appropriately. It doesn't mean that you have to have, for example, the over-the-scope clip in every room for every colonoscopy, but certainly some amount of clips. And also, most importantly, that your staff, your nurses and techs know how to use the clips. So if you have clips from different companies, but not everybody is familiar, make sure that as you are keeping things in the room, everybody is well trained, because everything works just a little differently.
Okay, so what about sedation? Because it can be painful. Patient is moving, makes your life more difficult?
Yeah, it can be painful, so you ask your nurse or your anesthetist, if you're working with them, to keep them calm, keep them sedated if the patient's having pain, maybe a little bit more anesthesia. You do have to obviously ensure that they're stable from a vital signs point of view, hemodynamically, that the perforation is not causing some effect perhaps on their blood pressure or heart rate.
So back to the small hole, the large polyp, half is resected. Would you consider, you know, isn't it important that there is some distance between the hole and the further resection site? That if you place a clip now, it's not in your way?
Yes, absolutely.
Because you could do that, right?
Yeah, absolutely. So if the perforation itself is free of polyp, then I would consider, for example, closing from the edge of the polyp, even including some of the underlying muscle. But you don't want that the clip gets in the way of whatever tool it is that you're planning to use for the further resection. So with ESD, it's a little bit easier because you can really control where you put the knife. But with the snare, you have to be a little careful because it may catch the clips. So again, if it's very small,
you need more distance, maybe.
You need more distance.
Mm-hmm. Okay. If there are any questions, raise your hand. I think there are micros available. Good. So resection completed. I think what's very important is the Michael Berg developed these signs because there are obvious holes, but there are holes to come, right? Where there's this whitish rim, here's class 3. I'm not sure whether everybody's familiar. Do you use that?
With the Sydney classification? I don't routinely say with every lesion what type of perforation. I think it's more important to use as a tool for recognition. When have you completely gone through the muscle? When have you just had a defect on the muscle, but the muscle is still intact? Because the key is that if you haven't gone through the muscle, you don't necessarily need to close the defect. If it's on the right side and it looks a little deep, then I would close the whole defect in order to relieve the tension and prevent any delayed perforation. But if it's just a small, nick or you see the whitish material, this is not something you have to worry about. Certainly not something you have to stop the procedure for.
But at least he recommends to clip this. That's the type 3 where you have the whitish ring.
Yeah.
And the assumption is that during the healing process or after colonoscopy, this may open up secondarily.
Yeah.
Another question, Amrita, clipping. Should it always start at the mucosa? Or do you have to afraid to clip intramuscularly?
So that's a really interesting point, is that I think the techniques have evolved. I think Professor Yahagi is here, actually, but now there is even described the origami technique, where instead of trying to bring the edges all the way together, where you have a lot of tension, there's actually the thought now of let's oppose the tissue in a few spots to decrease the tension and to make it easier to actually have a good mucosa to mucosa apposition. So, for example, you can do this with clips and the technique where you take some of the muscle, you take the mucosa to the muscle, and you bring it together in like 3 rows, and all of this brings the defect closer together, and then ultimately you're able to place a clip over that catches both sides of the mucosa. Or there are other devices now that are available that help you do that. For example, there are tissue apposition clips like the Mantis clip or the dual action clip by Microtech, where you can open each side, or you can open the clip, you can grab one side and you can move it over to the other. Again, saying that you can deal with larger defects and you can also manage the forces of the edges kind of trying to separate. And then, of course, there are things like X-Tac by Boston Scientific, where you're first just placing the tacks on each side, and then after placing them, you're drawing it all together, bringing the edges closer together, decreasing the tension, and then you can place a clip over the defect. And there's more security in that closure because you've brought the edges closer together.
Okay, back to our hole. Let's say it's a small hole. It's always clips, right? Any difference how sharp the ends should be, or doesn't it matter?
No, I don't think it really matters too much, as long as you have some good purchase of tissue, like you've grabbed a good amount of tissue.
So any clip works, more or less?
I think any clip would work, more or less.
For a small hole, clip size, how should it be adapted?
I think in general, I tend to go for larger clips, about 16, 17 millimeters. But if it's really that small, you could even use smaller clips like 11 or 12 millimeters. I think you just have to gauge for yourself. You want to make sure there's enough the clip is large enough that it can gather a good amount of tissue on each side, not just one side, but on both sides.
Right. So that you should not be afraid if there's a large defect to clip just the muscularis. But here, if you start with larger clips, you're rather going for closing the entire defect together with the intramuscular perforation.
Yeah, whether it's closing it in a zipper fashion so that you're slowly bringing it all together, or doing these different other techniques of opposing the tissue.
So what's the hole size, the defect size, where you consider something else? So clip might not be enough.
So I think
then it becomes A, more expensive, and B, you might have to withdraw the scope.
yeah, although now with the X-Tac, you don't necessarily have to take the scope out. So I think...
So should we, sorry for a second, does everybody know the devices we are talking about? Amrita was talking about that clip which hooks into the mucosa. It's called Mantis.
The Mantis clip.
Another, the DIT.
Yeah.
Clip.
So we'll, to confirm, the Mantis clip has like a very sharp 2 prongs on the end of the clip. And what it allows for is you open and you close, and it sort of hooks into the mucosa so that you can actually pull the tissue over and open the clip again, and it will continue to hold on to the mucosa because of the very sharp edges. So then you can keep the mucosa on one side of the clip, and then you take the other side and you can close the other edge. The dual action clip has individual prongs. So for example, if this is the clip, you open one side and then you open the other side. So you grab one side like this and you pull over, and then you open the other side, and then you deploy the clip with both edges in each individual prong. The X-Tac device is a helix tack. It's a metal tack. There are 4 of them, and they are all attached to a suture. So the device works that you the mechanism is called a Persian drill. It drills the tack into the mucosa. And so you drill one, and then you load the second tack, which is, again, attached to that same suture, and you go to another site. And you drill the second one, and so you drill the third one, and then the fourth one. And then, like the suturing system, you then use a cinch that will put tension on the suture, which brings all of the tacks together because they're all attached, and it cuts the suture the same way that the overstitch system does, for example. So it's drawing it all together. Again, the idea is an evolution in tissue apposition, which is really what we're talking about with closure.
But I also understand, you mentioned it before, when you do this mucosal apposition, you rather play safe and put an additional clip?
Yeah, particularly for this X-Tac device, because the suture itself is not going through the actual mucosa. The suture is kind of running along the top of the tacks. So you're bringing the tacks together. The tacks are attached to the mucosa. Yeah, so sometimes there's little gaps. And so just for security, I think it's now you have the tissue very close together, you can place another clip.
Okay, so this is kind of stepwise approach. Still the scope stays in with all those devices?
With any of the through the scope clips, the scope stays in. With the X-Tac device, the scope stays in because there is a colonic length clip that device that goes through, or an upper scope. So you can really use it with any scope. If you want to use the over the scope clip, there are 2 of them currently on the market. These are very large clips with deep teeth that are mounted on top of a cap. The cap has to be mounted onto the scope, which means the scope has to come out so that you can put the clip on. So those 2, the scope has to come out. That's why you really have to think about where you are. It's
better for left-sided.
Right, exactly. Yeah. And then the overstitch device is something that also has to be mounted onto a scope. So that means taking the scope out and setting up the device. There is a through the scope suture called suture art, which can be inserted through the channel of the scope that you don't need to come out also. But this is
yeah,
a
but
very...
you have to take the needle in.
Yeah, you have, right, you have to take put the needle in. So, and that's very particular. It's not something I would really say you would use for acute perforations.
Well, there's not enough experience. It's a little bit tricky to handle,
Yeah.
and you need enough space, etc. But we basically don't know enough. So again, it's the stepwise approach, normal clips, special clips, other devices, which also shows an increase in costs, more or less, right?
Yes, definitely.
Okay, 5 minutes left.
So I think one observation I've had recently from just recent cases and thinking about the different devices you have is that I think it has really allowed us to push ourselves in how efficient and complete we are with our resection. So previously, whether we were performing EMR or performing ESD, if we ran into a lesion and there was concern about the depth to which the polyp was growing, or if there was a lot of fibrosis, and we said, you know, if I cut here, I'm going to have a perforation, so I'm going to stop. And what that means is an incomplete resection. It's an R1 resection. If this is cancer or if this is an advanced high-grade dysplasia polyp, you've subjected a patient to surgery to get completion of their therapy. But now I find that we can come across that situation, and if you know that you have the right tools available and that you have the skill to be able to close it, and the situation is calm, you can actually go ahead and do a complete resection and go as deep as you need to go to get all of the tissue out, and then close the lesion. And you have done the patient justice, because you've given the patient a possibility that you've done a complete resection. They're not going to need to go to surgery, or at least for staging purposes, that the reason that it is an advanced stage is because you purposely, cut through polyp tissue. And also, if you've done that, you save them from having to go to surgery because you did a complete closure. And these patients, again, really don't have to go to the operating room. They can even go home.
Although, if it's malignant, we get into the difficult piecemeal discussion with pathologists and oncologists, but that's beyond the scope here.
Yeah, that's beyond the scope here, but it does kind of also push the science of doing en-bloc resection.
It does, both ways.
Yeah.
So I think what Amrita is telling, you have a large polyp, you resect it, and you have this piece in the middle. It's either fibrous or a residual polyp. What's your favorite device? Surely you have to take out the scope?
With the large hole?
No hole as yet.
Oh, not holes
So
yet.
you want to resect deeper. You
Okay.
have a residual polyp tissue sitting in the middle, very resistant to your snare, can't be injected.
So that's where I think the full thickness resection devices are very good. Again, it depends on where you're located. If you're on the right side, you have to really consider how difficult it was to get the device there. But just for those of you who aren't familiar, the full thickness resection device is effectively the over-the-scope clip, but inside the clip is a snare. So what we're doing is we know that we're going to create a hole and we're going to cut all the way through muscle. So we close the potential defect before we cut. So it's a close and then resect technique. And it's very good for these large polyps where they're big and bulky and the very center is fibrotic or perhaps advanced, because in this situation what we can do is we can resect without worrying about seeding, because we're actually bringing all the tissue up and then we're including the wall in the resection itself. And so there's no concern that there's potential seeding. So I think if the situation allows, I think that's very good. They're size limitations. You have to be less than 3 centimeters to be able to do that. So it's called a hybrid FTRD technique. You remove the peripheral, you debulk it, and then bring it down to a central portion that you can then pull into the
They also call it trimming.
trimming.
Yeah. Right. So in the last 10 seconds or what, we haven't covered the intentional hole. Submucosal tumor, 3 centimeters, probably a big hole.
Yeah.
What would you do?
Again, I think it comes down to confidence in your skills and what tools you have available. Of course, if you can create a tunnel and remove a tumor, like a submucosal tumor with the stir technique or the submucosal tunneling technique, this is probably safest because at the end of the day, it's just closing a mucosotomy. But some of these lesions are too big, and also they're in locations where you can't do a tunnel technique. In those cases, you do an exposed yet full thickness resection. That means intentionally going all the way down to the level of the muscle, specifically cutting the muscle with a sort of normal margin, and then removing the tumor and ultimately closing the hole. Again, you have to pre-evaluate what tools you have available, how comfortable do you feel with your closure techniques, is the situation right, clean, is the patient stable? But this has allowed us to really push our boundaries and remove things very safely. Decompression techniques, putting a needle into the abdominal cavity, letting the air out, these are all things you train your team to monitor and be able to do while you're continuing your work, giving antibiotics, but it's really pushed the field of third space endoscopy.
Okay, Amy Kai is sitting here from Shanghai. They have a large experience in making big holes and closing them. I think that might be a topic for next year. So thank you very much, Amrita.
You're welcome.
Thank you.
Thank you.